Module 10, Interpretation of Pathology on Cone Beam CT Images. The anticipated learning outcomes from this module are as follows. In terms of knowledge and understanding, we anticipate that you will achieve an excellent knowledge of the cone beam CT appearances of dentoalveolar pathoses, and a good knowledge of the cone beam CT signs associated with non-dentoalveolar pathoses. In terms of skills and abilities, we hope that you will be able to view and analyze cone beam CT images in a systematic manner, that you'll be able to recognize the radiological signs of pathoses, and be able to construct a radiological report on a cone beam CT scan that effectively communicates the diagnostic information to others. Our overall judgment and stance is to strive for high accuracy in interpreting pathosis on cone beam CT images of the dentoalveolar region. The first question to ask is, who can and cannot interpret cone beam CT scans? If we look back to the European Communities Council Directive 97/43 Euratom, this defines the holder, that is the person with legal responsibility for a radiological installation, as being responsible for ensuring that clinical evaluation is performed by a practitioner. A practitioner is a medical doctor, a dentist, or other health professional who is entitled to take clinical responsibility for, in this case, clinical evaluation in accordance with national requirements. The Radiation Protection Cone Beam CT for Dental and Maxillofacial Radiology document, produced by the Sedentex CT project in 2011, makes two recommendations related to this. All those involved with cone beam CT must have received adequate theoretical and practical training for the purposes of radiological practices and relevant competence in radiation protection. Once an individual has received adequate training, continuing education and training after qualification are required, particularly when new cone beam CT equipment or facilities are adopted. A further recommendation is as follows. Dentists and dental specialists responsible for cone beam CT facilities who have not previously received adequate theoretical and practical training should undergo a period of additional training that has been validated by an academic institution. Where national specialist qualifications in dental and maxillofacial radiology exist, the design and delivery of cone beam CT training programs should involve a dental and maxillofacial radiologist. A dentist with a cone beam CT scanner in his or her practice might well ask the question, can I employ a radiologist to report, i.e. perform the clinical evaluation, my cone beam CT examinations? The answer to that question is yes, subject to the availability of a radiologist and the financial support required. But in the Sedentex CT project, a definition of what was suitable for an adequately trained general dental practitioner to report was made. In the basic principles for the use of dental cone beam CT, the consensus guidelines of the European Academy of Dental and Maxillofacial Radiology from 2009, two statements were agreed. That for dentoalveolar cone beam CT images of the teeth, their supporting structures, the mandible and the maxilla up to the floor of nose, for example 8 by 8 centimeter volumes or smaller fields of view, clinical evaluation should be made by a specially trained dentomaxillofacial radiologist or, where this is impracticable, an adequately trained general dental practitioner. For non-dentoalveolar small fields of view, for example temporal bone imaging, and all craniofacial cone beam CT images, where the fields of view extend beyond the teeth, their supporting structures, the mandible, including the TMJ and the maxilla up to the floor of nose, clinical evaluation should be made by a specially trained dentomaxillofacial radiologist or by a clinical radiologist. The aim of this module is to try and provide adequate training for a general dental practitioner. As such, what we will contain within this module is broadly within the areas defined on these scout views from a cone beam CT examination. There is a lot of logic to this approach. In this area, dentists are reasonably familiar with interpretation of two-dimensional radiographs. As such, it is certainly feasible that training can be achieved to allow them to be competent in interpreting three-dimensional images. Clearly, outside this volume, dentists are not currently adequately trained to interpret two-dimensional images, so the interpretation of three-dimensional images would be very challenging indeed. Let's now turn to the basic principles of viewing images. The basis of viewing cone beam CT datasets is to navigate all the volume in a systematic way. Going straight for the part of the image volume of primary clinical interest means that other findings will sometimes be missed. The best approach is to start with the scout images. These are part of the X-ray examination and may show abnormalities which are not included in the CBCT volume itself. This means that there's a good argument for trying to make the scout images as small as possible, within the bounds of them being useful for planning the cone beam CT examination. This means that a lot of areas are excluded from the scouts, and therefore there is less of a challenge in interpreting them. For example, look at this case here, where the scout images were taken prior to cone beam CT examination to plan implants. Overlying the right orbit, you can see a calcification arrowed on this image. This turned out to be a brain tumour. Similarly, here on this patient, the scout image shows a calcification running down the centre of the cranium. This was calcification of the falx cerebri in a patient with Guilin syndrome. Having checked the scout views, it's then important to optimize the image quality. When you acquire the CT images, very often they are not optimized for contrast and brightness, and your first task is to make this as good as you can, subjectively, of course. In addition, you should optimize the image quality of the volume rendered images, which are not always in ideal situation at the start. This means thresholding them to what appears to be an appropriate level. Once you have made the image quality acceptable, then you should conduct systematic viewing of the images, in particular the scan volume itself. Everyone can develop their own approach to this, but the important aspect is to scroll through the entire volume from top to bottom in each of the three main planes. First, the axial plane. Work your way through this from top to bottom, or if you prefer, from bottom to top, until you have covered the entire volume. It's often useful to keep a piece of paper and a pen close by you when you're doing this, to make a note of any findings that need more careful checking later. Repeat this in the coronal plane, followed by the sagittal plane, until you have been through the volume in three different dimensions. This will allow you to pick up incidental findings. For example, on this patient who underwent a cone beam CT examination to look at the upper teeth, we identified on the very periphery of the scan a small calcification in the floor of mouth. This was a submandibular calculus. Note also that this patient has got some inflammatory tissue in the left maxillary antrum, which may well be significant. Let's look at that in a bit more detail with another patient. You will find when conducting cone beam CT examinations of the upper jaw that you will encounter inflammatory changes in the maxillary sinus and nose quite commonly. If we look at a close-up of the axial scan of this patient, you can see the black areas in the center of the maxillary antrum aligned with a grey area bordering the walls of the antrum, which represents mucosal thickening. This indicates chronic sinusitis. Note also in the right nasal cavity there is mucosal thickening overlying the inferior nasal concha, indicating inflammatory disease here as well. Finally, look at this scan of a young girl who was examined with cone beam CT to look at her anterior teeth. What you can see here is a radiopaque mass within the right nasal cavity. This turned out to be a foreign body which the child had pushed up her own nose. Once you have been through the scan volume systematically in 3 planes, then is the time to concentrate on the areas of primary clinical interest. In this case, the upper left central incisor. Your first task is to center to the point of interest. The next task is to rotate and to tip the scan volume appropriately. Now, by appropriately here, we mean so that the object of particular interest, in this case the incisor tooth, is aligned with the principal planes of the scan. This is particularly important when looking at the roots of teeth. It's also useful when looking, for example, at third molars. Here we can see a third molar cone beam CT scan in the acquired planes. The coronal scan on the bottom left-hand side of these images, you can see shows a very oblique view of the third molar. It's not ideal to interpret the findings. So by simply rotating and tipping the scan appropriately, we get a far better view of this tooth. Once you have got the scan volume in an ideal orientation, slowly scroll through the area of primary interest. Now, for the purposes of this PowerPoint, we've taken static images and assembled them in a stack, as you can see. But in reality, you will be slowly scrolling through the volume, sometimes going back and forth, until you have achieved the ideal image, the one that's giving you the most useful information in that plane. You should then repeat this in at least one other plane. Only by doing this will you get all the required information. Once you've gone through this process, it's time to think about multiplanar reconstructions. The one that most people think about first is the panoramic reconstruction. This often provides no more than a familiar image to help you in orienting yourself for other cross-sectional images, but this is in itself a valuable thing. Don't forget that panoramic images do not need to follow the complete arch, so if you're conducting a small volume cone beam CT scan, just covering a small section of the dentition, you can still produce a panoramic type image of this small region, as shown here. When you're producing a panoramic multiplanar reconstruction, you should set the slice thickness of the reconstruction somewhere between 10 and 20 millimeters. This helps to avoid the pseudoforamina, or holes and missing information produced by anatomy lying outside the section thickness. On the right of the image here, you can see a very thin panoramic reconstruction, and the odd appearance, particularly in the mandible, is a result of this very thin section. By increasing the thickness, we can see that we're gradually producing an image which is more classically like a panoramic radiograph, and provides more useful anatomical information. Having completed our panoramic reconstruction, we can produce cross-sectional reconstructions for implants or for particular teeth. Remember also that your cross-sectional reconstructions do not need to follow a panoramic plane. Here we're just looking at our single tooth here, our incisor tooth, and we can do this not only in this particular plane here, but also in a plane at right angles to it. In fact, you should perform reconstructions in various planes to produce the best diagnostic information for each particular case. Let's move on to interpretation itself. The basis of identifying and interpreting pathosis on medical images is an excellent knowledge of anatomy and its normal variations. When something cannot be definitely classified as anatomy, the next step is to exclude artifact as a cause of the abnormal appearance. The classic cause of artifactual appearances on images on cone beam CT scans is of course metal beam hardening artifacts, as we can see here, arising from amalgam and gold restorations in teeth. If we move on to pathology, well, we've got an enormous list of possibilities that may arise on examination of dental cone beam CT scans. These include very common abnormalities and diseases like dental caries, periodontal disease, and so on. It also includes some rather unusual pathologies and anomalies which you may see only very occasionally. In this module, we will concentrate on the common findings that you will see and just give you some examples of the more rare conditions. Indeed, no general dentist can be expected to give a perfect diagnosis on cone beam CT of these uncommon conditions. The important thing is to recognize that something is abnormal and to refer the patient to a specialist as appropriate. Let's start with the real basic dentistry, the interpretation of dental caries. There is limited diagnostic accuracy of cone beam CT in the presence of metallic restorations, as you can see here. But dental decay is a common chance finding, and so it is worth, when looking through your cone beam CT scans, for any definite identification of dental caries. The problem, however, is the artifacts produced from metallic restorations, producing pseudo-caries. However, where there are no potential causes of artifact, in other words, no metallic restorations in the teeth, it is worth checking for dental caries. These bitewing-like sections through a cone beam CT scan were produced where this patient had no metallic restorations, and we can identify many carious lesions. Remember also that one advantage of cone beam CT is that you can scroll through individual teeth in different planes and get an idea of not only the presence of dental caries, but its extent buccolingually. But you must beware of false positive diagnoses. For example, here on this cross-sectional image of a lower left second molar, we can see possible caries below a restoration, cervically on this tooth, and also possible recurrent caries below the restoration occlusally. I cannot be absolutely confident about the presence of dental caries in this tooth. The fact that there are metal restorations there means that I would be reluctant to report caries in this patient. Another very common task performed by dentists is the identification of periodontal bone loss. We should not forget, however, that the primary diagnostic method of identifying periodontal disease and periodontal bone loss is clinical examination, for example using a periodontal probe. Conventional radiographs can be used to give an impression of the bone loss, but this is of course restricted to 2 dimensions. Nonetheless, there is no international or national consensus on the value of radiography in identification of periodontal bone loss. Nonetheless, when you look at your cone beam CT scans, you should make an assessment of the periodontal bone levels around teeth. The normal crestal periodontal bone attachment is around 1.5 to 2 millimeters below the amelocemental junction, as shown here. When looking for periodontal bone loss, a key sign is always loss of lamina dura and the periodontal ligament space. On the image on the left of the screen here, you can see an upper right 6. Look into the furcation and you will see no lamina dura and no obvious periodontal ligament space. The use of the volume rendered or 3D images to examine the periodontal bone condition may be tempting to use. If you do this, it's very important to remember that incorrect thresholding may introduce apparent periodontal bone loss when it is not present. These 3 images here are all of the same patient and produced from the same data set. You will see that the image on the right certainly gives the impression that there is quite severe periodontal bone loss, when the truth is represented by the image on the far left. Another common diagnostic task is to assess periapical inflammation. We're familiar from 2-dimensional radiographs that health is indicated by an intact lamina dura and a consistent width of the periapical periodontal ligament. We can see that here on this canine tooth in the upper jaw. The presence of periapical inflammation is indicated by loss of the periapical lamina dura and or widening of the periapical periodontal ligament. Both of these teeth here show this kind of feature. On the right, we're seeing a cross-sectional image of an upper premolar, and we can see that around these 2 apices that there is a widening of the ligament space, loss of lamina dura, and a diffused radiolucency. Here again, we can see a patient who's got some inflammation around a previously apisected tooth, and we can see a widening of the ligament space. Note also the mucosal thickening in the maxillary sinus. Occasionally, this can be secondary to dental inflammation, either periapical or periodontal, although in this case it's difficult to prove that. If chronic periapical inflammation persists, this often develops into a well-defined spherical periapical lesion, which we call a granuloma, that is a ball of chronic inflammatory cells, as we can see here on this lower left lateral incisor. Loss of overlying cortex leading to a fenestration of the cortical plate is also seen in a granuloma, but is also a feature of chronic abscesses. Let's move on to think about resorptive lesions, a common form of which is inflammatory resorption. Here we see an example of inflammatory resorption on a root-filled tooth. This tooth had been traumatized quite severely in the past, had become non-vital and had undergone endodontic treatment. You can see on the various scan sections here patchy resorption of the external surface of the root. With inflammatory resorption such as this, there is usually some related radiolucency of the bone. Here we see another form of resorption, in this case associated with some impacted teeth, 2 impacted canines in fact. And we can see the resorption of the central incisor roots, which is quite severe, in association with the follicle of each of the impacted teeth. We also see patients with idiopathic resorption, in other words, where we can identify no obvious cause. This patient presented to their dentist with a pink coloration of the central incisor that is arrowed. You can see a very tiny defect at the cervical margin of this tooth. On the cone beam CT scan on the right, you can see how the resorption has undermined the labial enamel, and in fact there is very little dentine between this area and the pulp. Cone beam CT is also sometimes used to assess patients with suspected internal resorption. This is seen on CT scans as a localized enlargement of the pulp chamber or of the root canal. And you see a loss of the outline of the root canal when looking through the scans. There is also, as you can see, a periapical granuloma on this tooth. You should contrast this with external resorption, where the maintenance of the outline of the pulp can be seen. Of course, there are cases of resorption such as this, where the origin of the resorption, internal or external, is impossible to determine because the lesion has extended so far that it is not only involving the pulp but also the external surface of the tooth. Another use of cone beam CT that has been recommended is its use in dental and bony trauma. Let's just think about some general radiological signs of trauma. We're looking for radiolucent lines. With teeth, we're looking for periodontal ligament space widening. For both teeth and bone, we're looking for step deformities at boundaries. We may also see soft tissue swelling. And as a later change, we may also see adjacent bony radiolucency forming. The scan on the right here shows a fracture through a central incisor. You can see it best on the sagittal image, which is the one on the top right. Here is another patient who received some quite severe trauma to his upper anterior teeth. What we can see here, if we look very closely, is a fracture line on the palatal aspect of the upper left one. We also see it here on the coronal section through this region, and again we see it here at another sagittal section. The image at the bottom left is another coronal section through a different plane to the one previously on the palatal aspect of the teeth, and we can see an alveolar fracture running horizontally through this region. We also note on the cross-sectional image widening of the ligament space around upper left one. Trauma can also be iatrogenic. Here is a patient who underwent removal of the lower left third molar. Unfortunately, during the extraction, the tooth was apparently lost. The cone beam CT scan demonstrates that much of the tooth had been displaced in a lingual direction, and we can see this very clearly on the volume rendered image here. One of the commonest of all uses of cone beam CT in the dental region is the assessment of impacted teeth. As we know, the commonest teeth to become impacted are third molars, maxillary canines, and second premolars. However, just because an impacted tooth is present in the patient does not mean a cone beam CT is justified. CBCT may be indicated when three-dimensional information is likely to alter a treatment plan. This may be because of things like resorption, potential surgical complications and challenges, potential orthodontic obstructions to movement, or associated disease. When we're looking at an unerupted tooth on a cone beam CT scan, we should look at the images in a systematic manner. An approach is illustrated here. We can look at the tooth position or impaction type. We should look at the pericoronal follicle space, followed by the root shape and number of roots, the presence of caries or resorption of the tooth itself, the condition of the related teeth, for example, resorption, periodontal bone loss and caries, and we should also look, where relevant, at related structures of importance, for example, neurovascular canals. So let's try and do that. Here we have an impacted upper left canine. So our first task is to assess its position and impaction type. Well, from the panoramic reconstruction, we can see it is a mesioangular impaction. By looking at the axial scans, we can see that the crown is lying palatal to the line of the dental arch. We can also see that the root is lying above and approximately in line of the dental arch. So we've now defined its position. We should look at the pericoronal follicle space to determine whether any cystic changes occurred. And we can measure that, as shown on the right here, using our measurement tools on the software. A normal follicle should be less than 2 millimeters in thickness, but can be 4 millimeters and still normal, in other words, not cystic. We then look for root shape and number. The easiest way to do this is to align the scan along the root axis, and this allows identification of dilacerations and other forms of curvature of the root, which may be relevant to orthodontic movements or to surgical treatment. We should also assess the tooth for presence of caries or resorption itself. Here we can see an unerupted canine where there has been quite extensive external resorption. This may be important if the tooth is going to be extracted, but certainly would be important if anyone had planned to move it orthodontically. It's important to check the condition of related teeth. In the case of impacted canines, the question is usually whether there's resorption of an incisor. For this, you should align or upright the tooth of interest and scroll backwards and forwards in one of the three planes to identify the presence or otherwise of root resorption. You can also perform reconstructions in a panoramic or other plane in order to help you interpret the presence of resorption. Here we can see a tooth that was suspected of resorbing the incisor, but in fact, although there is resorption at the apex of this tooth, there was no additional resorption present on the palatal surface. Here we see some impacted canines where there is certainly extensive resorption of the upper right lateral incisor, extending indeed into the pulp of the incisor tooth. A final task is to assess related structures of importance, for example neurovascular canals. This is usually a task when we're examining mandibular third molars for their relationship with the inferior dental canal. For example, in this case, where the canal is located very close to the apices of this tooth. When you're performing this task with a lower third molar, it is important to get the best possible image. Here we've done some cross-sectional images, one of which you can see on the bottom right, and we can see the relationship between the inferior dental canal and the root apex quite clearly. But generally, it is best to upright the patient's jaw so that the inferior dental canal lies horizontally. This will give sharper images of the inferior dental canal. By rotating the volume so that the inferior dental canal is positioned horizontally, we get a sharper cross-sectional image of the inferior dental canal, as you can see here. Generally, this is good practice when preparing cross-sectional images. Let's now move on to anomalies of teeth. Well, there are an enormous number of anomalies of teeth which can occur, many of which can be diagnosed clinically and by using conventional radiography. Cone beam CT can play a role in managing tooth impactions, including supernumerary teeth, and defining the structure of tooth malformations, for example, dilacerations, dens invaginatus, and odontomes. But just because an anomaly is present does not mean a cone beam CT is indicated. There has to be some underlying way in which that cone beam CT will contribute to patient management. The scan dataset you see on the right here shows a dilaceration of the upper right central incisor. In this case, this examination was of clinical value because the orthodontist was trying to determine whether it would be feasible to upright and bring this tooth into the arch without the root apex emerging buccally. Here we see an anomaly, dens invaginatus, a very common anomaly of particularly lateral incisor teeth, although it can occur in any tooth. Note the invagination on the palatal aspect of the lateral incisor. This imaging is also helpful if an endodontist is planning to do treatment of a tooth like this. This particular case shows a compound odontome, characteristic features of which are multiple small denticles in an area that's quite restricted and well defined. The usual size of these is about 1 centimetre and most commonly located in the anterior regions of the jaw. Another anomaly, which is shown particularly well here by cone beam CT, is a gemination. This is where a tooth attempts to divide to form two separate teeth, but does so incompletely. Another very common anomaly of teeth is hypodontia. Here we see an example of a patient who has only got a few permanent teeth present. We have retention of deciduous teeth, particularly the molars in all 4 quadrants and of the lower anterior teeth. We also see submergence of the molar teeth and probable ankylosis. But why should we take a cone beam CT of patients like this that we can examine clinically or on simple conventional radiographs? Well, the answer is that very often these patients do go on to need implants, and the cone beam CT provides the assessment of bone quantity that is required in many cases before implants can be placed. It is important, however, to remember that we should not simply perform a cone beam CT examination unless there is some indication for implants or other intervention that may be taking place. Another anomaly is hyperdontia, where additional teeth develop in the dentition. And here cone beam CT can sometimes be useful. Why is that? Because very often it is difficult to interpret which are the normal teeth and which are the supernumerary teeth. In addition, if an orthodontist plans to move teeth into normal position, we need to have a very exact understanding of the interrelationships of the teeth. This is a particularly striking example where this patient has multiple unerupted supernumerary teeth. In fact, this is a patient with cleidocranial dysostosis. Here we can see some three-dimensional or volume rendered images, and you can appreciate here how much easier it is to try and interpret relative positions. Let's now look at radiolucencies in bone. Possibly one of the commonest situations where a dentist is presented with a truly diagnostic challenge when looking at radiographs or CT scans. Radiology is rarely diagnostic, that is in the pathological sense, when we're dealing with radiolucencies in bone. The role of imaging is to identify the presence of a lesion, to make a broad assessment of its nature, and perhaps a differential diagnosis, to demonstrate its extent and relationships, and most importantly, to assist the surgeon in treatment planning. So we will talk basically about radiological signs. Benign features of a radiolucency seen on a radiograph or cone beam CT scan are a well-defined margin, a round or ovoid shape, displacement of adjacent structures, including teeth, and jaw expansion. In contrast, aggressive features on radiographs or CT scans that should alert you to the need for more specialist opinion or a more urgent treatment are ill-defined margins, an irregular shape, sometimes there is no displacement of structures, and destruction of cortical bone. The benign features are classically seen in cysts, anatomical features, and healed defects after surgery, whereas the aggressive features are seen in infection, malignancy, and sometimes in healing lesions. Probably the commonest radiolucency that a dentist is likely to encounter is a radicular cyst or periapical inflammatory cyst. This is very familiar to the dentist from conventional radiography, and the difference on cone beam CT scans is simply that our round lesion on a two-dimensional image becomes a spherical periapical bone defect. It is well defined, expansile, and sometimes causes resorption of adjacent teeth. This is an example of a radicular cyst, however, which is very large and located within the maxillary sinus. Here we can just about see an edge to this lesion. It is occupying almost the entire size of the maxillary antrum. Here on the axial scan you can see the expansion posterolaterally. Dentigerous cysts are the second commonest form of odontogenic cyst. These are spherical or ovoid pericoronal bone defects, commonest on third molars and maxillary canines. They are well defined, they're expansile, and sometimes cause resorption of adjacent teeth. Remember, we said earlier a normal follicle can be less than 2 millimeters, but maybe up to 4 millimeters and still be normal, i.e. not cystic. So take care not to overdiagnose the presence of dentigerous cysts. Here we see an example which is definitely a cyst and not just enlarged follicles. This is a dentigerous cyst associated with 3 unerupted teeth. You can see on the bottom right, the volume rendered images, that the bone has become so thin that we're seeing through into the cavity and we can just see the crown of one of the unerupted teeth through the window. The cross-sectional image on the top right shows the thinning of the cortex and a little bit of expansion. This section a little further laterally shows the expansion at the lingual aspect of the mandible better. There are, of course, many uncommon cysts and tumours that can arise in the jaws of patients. But, of course, none of these are likely to be treated in general dental practice, so the priority for the dentist interpreting the scans is identification that a lesion is present and then undertaking referral to the specialist who is actually going to treat the patient. Here's an example of a nasopalatine cyst in the midline of the maxilla produced by an enlargement of the nasopalatine canal. Here is another reasonably uncommon cyst, the keratocystic odontogenic tumour, previously known as a keratocyst. On this particular example, which is in the classic site in the jaws of the third molar region, we can see that we've got some resorption of the distal root of the second molar. Note also that this particular type of cyst tends not to expand the jaw as much as other cysts due to its method of growth, and we can probably appreciate the lack of expansion on the axial scan. Here we see a cross-sectional image, and the asterisk denotes the inferior dental canal, while the CT scan here was never diagnostic of a keratocyst. It did help the surgeon considerably by demonstrating the position of the inferior dental canal so that during surgery this was less likely to be damaged. Note also the resorption of the root of the tooth included in this section. Compare those previous images with this one. This is a classic example of an aggressive looking radiolucency. Here we can see a malignancy. This is metastatic carcinoma. But the same kind of ragged, ill-defined margins to a radiolucency can also be seen in osteomyelitis. This is the same patient on the 4 principal planes. And here are some cross-sectional images. Note that the teeth themselves probably haven't been disturbed from their normal positions. They appear to be floating within the abnormal tissue. There is extensive ragged bone destruction. Here's a different case. This is osteomyelitis. And here we can see a very irregular radiolucency with ragged margins and destruction of the lower border of the mandible. Centrally within this, I think you can probably appreciate that there is a piece of bone which is detached from the surrounding bone. This is a sequestrum of dead bone. Here we see the same patient on a volume rendered image and also a cross-sectional, showing the bone apparently dissolving away due to the spread of the infection and sequestration of bony fragments. Apart from radiolucencies, we also come across radiopacities on radiographs and on cone beam CT scans. Now most of these, of course, are going to be teeth and roots. If they are roots, then they should have characteristic shape and density, a periodontal ligament, and be in the appropriate sites of where teeth and roots are likely to be found. For example, here on this scan taken for implant planning, we can see a retained root in the lower premolar region. You can just about make out a thin periodontal ligament space, and on at least one of those 2 sections, something approaching a root canal. These characteristic features would lead you to diagnose a retained root. However, one of the commonest radiopacities that causes challenges to dentists is idiopathic osteosclerosis, or a dense bone island. The picture on the top right shows a panoramic reconstruction from a cone beam CT scan. It shows 3 radiopaque areas of differing size. These are idiopathic osteosclerosis. If we look at the scans of this patient, you will see an irregular radiopacity of cortical bone density and a very irregular shape. On the axial scan on the bottom left, near the top of the picture, you can see that the area of sclerosis is attached to the lamina dura of a particular tooth root. Here's another case where a conventional radiograph suggested that there was a retained root in this region. The scanners revealed very clearly that this is not a root because there is no peripheral radiolucency, the irregular shape, and certainly the absence of any kind of root canal. Another radiopacity which may be picked up on radiography or on cone beam CT scanning is a benign cemento-osseous lesion. Here's an example on a panoramic reconstruction from a cone beam CT dataset. This is a mass of cementum-like material. They may be multiple. They tend to start as radiolucencies and gradually become more calcified. They're usually related to teeth, often having a periapical location. They're commoner in African Caribbean patients. One feature that is usually present is an obvious peripheral radiolucency. On the scan sections of this same patient, you can appreciate the radiodensity present in the jaws and also the expansion, but you can also see the thin radiolucent line following its outline. This may mean in some particular cases that this can be interpreted as a dental structure or a retained root, although clearly in this case the lesion is too large to be either a tooth or a root. A bone disease, which is particularly common and does have implications for implant treatment, is osteoporosis. It is more common in women and has an increasing incidence with age. On this scan volume that you see on the right, you can see the typical features of a patient who has osteoporosis. We have a very thin cortical layer around the mandible, and we have sparsity of the trabeculation within the mandible. It is important to recognize these features if you're carrying out implant treatment. As a general rule, we should be looking for a cortical thickness of less than 3 millimeters in the mandible below the mental foramen at the lower border as a risk factor. Another risk factor is porosity in the cortices. And finally, sparse trabeculation within the jaw itself. As I said at the beginning of this PowerPoint, we do see non-dental, non-jaw pathosis on cone beam CT scans, and a very common form of this is maxillary sinus and nasal disease. It's probably the most common incidental finding on dental cone beam CT scans. Remember what a normal maxillary sinus should look like. There should be no visible soft tissue within it. All you should see is air. Here is another patient with a normal maxillary sinus appearance. No mucosa visible, but some mucosa visible in the nasal cavities. Chronic rhinosinusitis, or chronic inflammation of the maxillary sinuses and nasal cavities, is very common. Here is a good example. We can see the thickened mucosa surrounding the walls of the maxillary antrum. Here is another patient. On the axial scan, the left maxillary antrum appears to be completely radiopaque, although we can see on the coronal scan on the right that there is actually a fluid level within the sinus. Sinus mucosal thickening may also be picked up on reconstructions. This is part of a panoramic reconstruction of the upper right molar region, and we can see polypoid thickening of the mucosa within the maxillary antrum. Of course, there is a close interface between dental and maxillary sinus disease, and here is a case where there is a complete conjunction of the two. When you look within the sinus here, we can certainly see mucosal thickening, but we can also see the presence of 3 very well-defined radiopacities, and these were roots of a tooth displaced into the maxillary sinus during extraction. You should be also able to appreciate on the sagittal scan on the top right the defect in the maxillary sinus floor as a result of the displacement of the roots. There will always be cases where you identify an abnormality but cannot explain it or give a diagnosis. This is normal. There is no shame and little work involved in asking for a second opinion from a colleague or from a radiologist. Do not ignore something which you cannot reasonably explain. Here's an example of a patient where there was expansion of the left side of the maxilla. You can appreciate that very clearly on this axial scan. the bone is thicker buccolingually. And on the volume rendered image, you can certainly appreciate the bulbous expansion of the left maxilla. This turned out to be fibrous dysplasia of bone. Most dentists, ordinary general practitioners, would never be expected to make this diagnosis. As I said, the important feature is to identify it and refer the patient. Finally, let's look at constructing a radiological report. A radiological report records the information for future use. It acts as the legal record of the examination having been performed, and it communicates information to a referring dentist. In order to perform a radiological report, we've already talked about the systematic way that you look through a cone beam CT dataset. But in terms of actually preparing a report, it's useful to have a template available to you. Here is just an example, a suggestion for a reporting template. This should include information about the patient's name and unique identifier, the date in which it was performed, who referred the patient and who performed the report. We have space to record technical comments, for example if there were issues regarding patient movement, the volume size selected, and so on. A space to record findings on scout images. Often there will be nothing to report here, but it's at least a reminder to examine those images. Then the scan report, followed by any incidental findings on the scan which are not directly relevant to the clinical problem, and finally a section for a summary and comments, for example recommendations for further investigation. In conclusion, we have described how to view and analyze cone beam CT images in a systematic manner. We have outlined the radiological signs of diseases of teeth and bone affecting the dentoalveolar area. And we have described the content of a radiological report on a cone beam CT scan using the help of a reporting template. We acknowledge that the research leading to these results has received funding from the European Atomic Energy Community's 7th Framework Programme.